I'm now going to discuss causes of anisocoria. If there is a case of anisocoria, how will you reach upon the conclusion, right? So this is one of the most tricky topics in neuro-ophthalmology, and I'm going to simplify it for you. Now, just you have to listen to me. Everything is written, right? Just focus. Yes. So if the patient has come to you with anisocoria, which is more in dark room, so that means when the patient is moving from a bright lit room to a dark room, so there is anisocoria. That means ideally in dark room the pupil should dilate, but that means one pupil is dilating but other isn't. That is why there is an anisocoria. Yes, and the pupillary constriction action is due to sphincter pupillae, which is supplied by a third cranial nerve, which is parasympathomimetic. While when there is stimulation of dilator pupillae, the pupil dilates and it is sympathetic pathway action. Yes, so if there is more anisocoria on moving from bright lit room to a dark room, that means there is problem in sympathetic system. Yes, so one is getting dilated, another isn't. So how will you test that? So first drug you are going to use is 10% cocaine eye drops. So what is the mechanism of action of 10% cocaine? It is norepinephrine. It is norepinephrine reuptake inhibitor. That means if there is presence of epinephrine in the synaptic terminal or junction, so it will prevent the reuptake of norepinephrine. Yes, so if on putting 10% cocaine eye drops, if there is no effect, that means norepinephrine is not present there. If it is not present there, whatever amount of cocaine you put, there will not be any effect, because the mechanism of action is it prevents the reuptake. That is why it will have its prolonged effect. Yes, if there is no effect, that means it is not being produced. So you will think of Horner syndrome. But if on putting the 10% cocaine eye drops, there is a reaction. Yes, there is a reaction of the smaller pupil. You will think of physiological anisocoria. Done. Now you have diagnosed that okay, it is a case of Horner syndrome because there is no norepinephrine present in the terminal. Yes, so it can be preganglionic, it can be postganglionic. Now for that, if you could recall the Horner's pathway, it starts from hypothalamus, go till C8T1, then the sympathetic fibers move anteriorly, inferior cervical ganglion, superior cervical ganglion, then it loops around the carotid artery. Yes, and they will enter into the middle cranial cavity, from where it will proceed anteriorly and will enter into the orbit and are going to supply the sphincter, the dilator pupillae. Yes, now you put another drug, that is your hydroxyamphetamine drug. What is the mechanism of action of hydroxyamphetamine? This drug releases norepinephrine. It is releasing norepinephrine, which is ultimately going to cause constriction. Now if on putting hydroxyamphetamine there is dilatation of the pupil, so that means this terminal is fine, the stimulus is not coming from the back end. Yes, so that will make you think that it is postganglionic. This is preganglionic Horner syndrome. But if there is no dilatation on putting hydroxyamphetamine drop, you will think of postganglionic Horner syndrome. Yes, so what is the mechanism of action of hydroxyamphetamine? It releases norepinephrine in the synaptic terminal. Is it understandable? Yes, I hope you have understood. Now let's go on to the second scenario. Second scenario is when there is more anisocoria in the bright lit room. So when the patient moves from dark surroundings to a bright lit room, in the bright lit room the pupil should constrict, but if one is constricting, another isn't, so there is anisocoria. Anisocoria is difference in the size of the pupil. Yes, and significant anisocoria is when there is difference in the size of the pupil more than equal to 2.5 millimeter. This is significant. Yes, so now what you are going to do, you are going to use pilocarpine 0.125% eye drops. If on putting pilocarpine 0.125, what is the function of pilocarpine? It is parasympathomimetic. I am writing it here. It is parasympathomimetic. It binds to the postsynaptic receptors and cause the action. Parasympathomimetic. It binds and cause the action. Now on putting the pilocarpine eye drop, if there is sluggish pupillary reaction and you can also see the torn pupillary border, you will think of traumatic iris damage. Yes, and there is a condition which we have discussed in the previous video, that is Addy's pupil. Yes, in Addy's pupil, you know, there is denervated hypersensitivity. So because of the denervated hypersensitivity, the receptors are hungry. They are hungry. They are, waiting for the stimulus. And as a result of which, the moment you are going to put just 0.125% eye drops, so it is going to swiftly constrict the pupil. You are going to use pilocarpine 0.125% eye drop in both the eyes. In the normal eye, there will be slow constriction, while in the other eye, the eye with Addy's pupil, there will be swift constriction. That will make you think of Addy's pupil. Yes, Addy's pupil. So that is why we say that in Addy's pupil there is tonic near constriction. But if there is no effect, what you are going to do? You are going to increase the concentration of pilocarpine from 0.125% to 1%. Yes. Now, if on increasing the concentration there is constriction of the pupil, you will think of third cranial nerve palsy, oculomotor nerve palsy, the fibers of which supply sphincter pupillae. But if there is no constriction, even after increasing the dose, which is 1%, you will think of pharmacological pupil dilatation, right? So boys and girls, this is how you approach towards a case of anisocoria. This is very important. It can be asked in your viva voce examination. It can be asked in your university examination of your PG, university exam. Yes. Okay. So that was anisocoria. Now coming over to one disease, which is your optic neuritis. What is optic neuritis? Optic neuritis, as the name suggests, it is inflammation of the optic nerve. Now optic nerve, what is the length of optic nerve? The length of optic nerve is 50 millimeter. Yes. So this is your length of optic nerve. Now, if I divide optic nerve anatomically, there is intraocular portion. Yes. Intraocular portion, which lies inside the moment it enters into the eye. So it lies inside the eyeball. That is just 1 millimeter. Then we have got retrobulbar portion or intraorbital portion. Retrobulbar is the portion which lies inside the orbit. So it can be anywhere around. So it varies from person to person. It can be anywhere around 25 millimeter. There is a window, but yes, it can be anywhere around 25 millimeter. Then we have got intracanalicular portion. Intracanalicular portion is the portion which lies inside the optic canal. It can be anywhere around approximately 7 millimeter. Then we have got intracranial portion. which lies inside the cranium, intracranial portion. It may be anywhere around 12 millimeter, 10 to 12 millimeter. Intracanalicularis is 5 to 7 and retrobulbar is 25 to 30, near about. Yes, but intraocular portion remains constant. It is 1 millimeter only. Yes. Okay. Now anatomically, if there is inflammation of the just intraocular portion, you call it as papillitis. What do you call it as? Papillitis. But if there is inflammation of the retrobulbar portion of the optic nerve, you call it as retrobulbar neuritis. Yes. And if there is inflammation of just the neuroretinal rim, you understand, na? See, so this is your retina, this is your optic nerve head, so this is your optic nerve head. Yes, this is your optic nerve head. You know, optic nerve head consists of the cup plus neuroretinal rim. If there is just the inflammation of neuroretinal rim, you call it as neuroretinitis. Yes. So these are the three things that you should know. So this is based on the anatomy. Now there is also etiological classification. Etiological classification of optic neuritis. Etiological. So one is demyelination. If the cause is demyelination. So demyelination, one is Davik disease. Demyelination. Then we can have multiple sclerosis. Davik disease, we have multiple sclerosis. Then we can have isolated disease. So these three can be put under demyelination. Then we can have infectious cause. Infectious means Lyme's disease, syphilis, leprosy, infectious. So one is demyelination, second is infectious. So Lyme's disease, syphilis, leprosy. Third is autoimmune. SLE, systemic lupus erythematosus, even sarcoidosis. Yes, sarcoidosis. Fourth is para-infectious. So it can be due to vaccinations, viral disease. Yes, viral disease, para-infectious. Yes, I hope you have understood. Yes, so this is based on etiology. All right. Now coming over to this. So this I have already explained you. Now if there is involvement of the optic nerve head or there is involvement of neuroretinal rim, so of course there will be inflammation, optic neuritis inflammation. So it will cause optic nerve head edema. Yes, non-defined margins, even neuroretinitis. So these two conditions will have edema of optic nerve head. That is why disc margins will be blurred. But what about retrobulbar neuritis? The patient will come to the doctor and would say, Doc Saab, I cannot see anything. The doctor will ask the patient to sit down. The doctor will do fundus examination, will examine the disc. The doctor will say, patient, I also cannot see anything. So what does that mean? In retrobulbar neuritis, the disc margins are normal because of course there is involvement of the retrobulbar part which cannot be seen by retinal examination. Yes. So retrobulbar neuritis, the optic nerve head looks absolutely okay. है ना? While in papillitis, neuroretinitis, the disc margins they will be non-defined or blurred. In neuroretinitis, it is caused by one disease which is Bartonella-Hensley. Have you ever heard of cat scratch disease? Bartonella-Hensley. This Based on etiology, this can be infectious. Yes, Bartonella hensleyi is the organism, and it is your cat scratch disease. Cat scratch disease, and in which there is typical appearance of a macular star. Typical appearance of macular star. Okay, now what will be the clinical features? So first is sudden painful loss of vision. So there will be sudden, yes, there will be sudden painful loss of vision. One. Second, you need to know that the optic nerve, the outer sheath of the optic nerve is in contact with the sheath of superior rectus muscle. So there is typically, when the patient is having optic neuritis and you ask the patient to look upwards, there is typical pain on elevation, on ocular movements. Yes, so more specifically pain on elevation. Pain on elevation will be there. Yes, and what is dyschromatopsia? Dyschromatopsia is loss of ability to differentiate red and green color. Red and green color deficiency, typically red and green color deficiency. And okay, what is Uthoff syndrome? Uthoff syndrome is there is increase in signs and symptoms of optic neuritis on exposure to high temperature. If the patient goes for sauna, if the patient is a worker and working in broad sunlight, है ना? So due to intense heat, there can be increase in the clinical features of optic neuritis. There is another phenomena, you call it as Pulfrich phenomena. Pulfrich phenomena is the patient with optic neuritis will have a difficulty in assessing the depth stereopsis. The patient is not able to assess the stereopsis of an object and is not able to track the movements. If there is some object which is moving, the patient will not be able to track the movements. So stereopsis, loss of stereopsis, and perception of movement or movement perception will be absent. It will be absent. And RAPD, yes, you know RAPD, relative afferent pupillary defect, because you know the light reflex pathway, the afferent of light reflex is formed by the optic nerve, the efferent is formed by oculomotor nerve. We have done that in the pupil chapter, in the pupil part of neuroophthalmology. So when you shine the light in one eye, if the right optic nerve is involved, the stimulus is not going to the pretectal nucleus of midbrain. If there is no stimulus which is being received by the pretectal nucleus, there is no stimulation of internuncial fibers which are going to stimulate Edinger-Westphal nucleus. Hence, there will be no pupillary constriction. Yes, so these are features. Another is there will be, so one is Uthoff, then Pulfrich. There will be visual field defects. Yes, there will be visual field defects. So visual field defects, of course, one is generalized constriction of the visual field, generalized or generalized decrease in sensitivity, generalized decreased in sensitivity, generalized decrease in sensitivity. There can be altitudinal visual field defect, altitudinal visual field defect. Altitudinal means either on the upside the patient will not be able to see, or the downside the patient will not be able to see. So if this is your visual field chart, the perimetry chart, so if the patient is not able to see beyond the horizontal plane, the above the horizontal plane or below the horizontal plane, or like this, so this is altitudinal visual field defect. This is your altitudinal visual field defect. I hope it is clear. Yes, there can be central or centrocecal scotoma, central or centrocecal scotoma. Yes, and lastly there can be there can be enlargement of blind spot, enlargement of blind spot. So enlargement of blind spot is a very important thing, can be asked. It can be seen in papilledema as well. Just telling you that this question, enlargement of blind spot, was asked in your right now NEET PG 2024 examination. But yes, you can be asked enlargement of blind spot in your PG university examination as well. Yes, enlargement of blind spot can also be seen in papilledema. It can be seen in papilledema. And altitudinal visual field defect can also be seen in AION, anterior ischemic optic neuropathy. Anterior ischemic optic neuropathy. Is it understandable? Okay. All right. So there can also be, we have already done, you can go and check out the video. I am just recalling here. What is visual evoked potential? Visual evoked potential. Assess the pathway of the optic nerve or pathway of vision. So visual evoked potential will have decreased latency. What did I just say? It will have decreased latency. It will have decreased latency. All right. Now here you can see, so this is probably a case of retrobulbar neuritis, and this is your papillitis. Yes, you can see the non-defined margins here. What you can see the margins are pretty fine. The margins are pretty fine. All right. Okay. Now coming over to the treatment part. So for treatment, so there is one trial which you need to know, that is ONTT, optic neuritis treatment trial. So under optic neuritis treatment trial, what did they do? They divided the patients into 3 groups. So one was the group which received intravenous methylprednisolone 1 gram stat for 3 days, single dose 3 days, followed by 1 milligram per kg body weight of methylprednisolone into 11 days. So that was your one group. Second group was which received oral methylprednisolone. Oral methylprednisolone. ठीक है जी, oral methylprednisolone, and they received for 14 days. They received for 14 days. And third was the one which received placebo, and it was seen that the ones which received IV methylpred 1 gram for 3 days followed by 1 milligram per kg body weight. So there was visual recovery. Yes, so there was visual recovery which was actually faster. Yes, which was faster. But the same faster visual recovery was also seen in oral methylpred for 14 days. Now you'll say, sir, what is the difference? Why we are giving IV methylprednisolone along with oral when both have faster visual recovery? Mind you, what I am going to tell you right now, I am telling you that okay, this was there, but on giving IV methylprednisolone followed by oral methylprednisolone, there was more improvement in visual field, more improvement in more improvement in dyschromatopsia. Other features were improving, yes. So there was increase in the other features, yes.